Good afternoon, everyone. My name is Maya Luria with TMC for Seniors. And of course, we are in May, so it is Women's Health Month. And of course, what better topic to have than pelvic floor health? So, understanding common issues. I want to welcome Samantha Johnson here with me. She is with our TMC Adult Outpatient Therapy. How are you today, Sam?
I'm good. Thanks for having me again, Maya.
Yeah, so Sam, you always do such an incredible job of really sharing about the pelvic floor. I know you have a lot of passion. You brought
Yes.
your pelvis with you today. You have a model, so that was great. So I know you'll be showing that as well. I'm going to go ahead and put your PowerPoint up for you. You do have an online audience that's watching from home, along with an in-person audience today. If you're watching from home and you have a question for Sam, please go ahead and put those questions into the chat and I will ask Sam afterwards. I'll let you go ahead and get started.
Wonderful. Thanks, Maya. So thank you all again for coming. Maya is always nice enough to ask me to come and do a presentation about the pelvic floor for Women's Health Month, which is one of my passions. This is entirely what I do. Are we able to? Okay, this is entirely what I do. I work with just pelvic floor, and then the areas that are adjacent to it. There's often quite a bit that goes into this. So today I've got a couple different topics for you that I choose based on what I'm hearing a lot from my patients in the clinic or what I've learned something new about recently. So I always like to start with an anatomy clarification because what I find is a lot of times we're using words that aren't exactly what we meant for the structures that we were talking about. And I think it's really helpful to know these things so that when you're talking to your healthcare provider, you can make sure that you're on the same page as them. So when we're talking about the external genitalia that you would take a hand mirror to be able to see and check and look at, we're talking about the vulva. This is what a lot of times colloquially we'll call the vagina, and that is actually not correct. The vagina itself is this tube that is just, I don't know where my pointer is, this tube here that's a hollow tube. When we have any sort of penetrative intercourse or when we're having a baby, this is what it passes through during an actual childbirth. When we're talking about the uterus, we're talking about the womb or the structure where the baby grows inside of the body, where the menstrual fluid originates from. I also like to talk about what is the pelvic floor because you're all here. So I think you have a concept that we're talking about things to do with the bowel and the bladder, but what is the pelvic floor itself? The pelvic floor are the muscles of bowel, bladder, and sexual function, to make it really, really simple. So these are the muscles that help to control when we need to urinate or when we need to defecate. These also help as far as our sexual function. There are muscles of orgasm. They also have other roles. They're part of our core muscular system. So they help to keep us upright and moving in space. They also help with our breathing and they help with keeping blood flow moving through our body. They assist with our posture as well. One of the things that the pelvic floor is very important for is supporting the organs that live inside our pelvis. Now, it got a little too chaotic, so I didn't bring my organs with me today, but I did bring the pelvic floor so that you guys can have a little bit more of an idea of a three-dimensional structure. So the pelvis itself sits roughly like this in space. It's a little tipped forward from what I think we all think of when we think of a diagram of the pelvis. And the organs live down in this little basket right here. And so therefore, these muscles are what are helping to hold them in space. So what is a pelvic organ prolapse? So if you or anybody you know has ever had where their uterus starts to fall out, or maybe their bladder has slipped, or maybe their rectum has slipped, that's what a pelvic floor organ prolapse is. There we go. I also like to clarify for my patients, this is a common question, and I think that a lot of times when we talk about prolapse and we talk about things coming out, it gets very, very scary. So I like to clarify, it's not either in or out. You can have a little bit of a prolapse and you can live that way for a very long time without having any issues. It's not usually until it gets to a very severe degree, like you're seeing with a couple of these pictures that it really starts to become problematic for people. But at the same time, you could be somebody that's very sensitive to where your organs are situated, and therefore it is having more of an impact on how your systems are functioning and how your body control is working. A certain amount might even be considered normal. We just don't actually know that yet. And there's a lot of things that you can do that don't involve surgery. It may be that surgery is the best route. Once things have started to come down, doesn't matter how much exercise I teach you or how many things we do, we're not going to fix that. The ligamentous structures that hold those organs in have now become compromised. But you can get things like a pessary. There's other over-the-counter internal supports that you can insert into the vaginal canal that helps to hold those organs inside. Some situations will require a surgery, often a grade 3 where the tissues of the vaginal canal are at or coming out of the vaginal opening, or grade 4 where they are coming out of the vaginal opening and they are not going back in. Those are ones that often do best with a surgery. And then there's also this little guy called an enterocele that is a little bit different. It's where the intestine itself is coming down, and we really don't want that. That's not good for your bowels. So that's often one that is managed with surgery. This is a little bit more of an FYI. I think you guys should have this chart. I hope I made it big enough that it's legible. These are the words. So when you get that report, that MRI or the ultrasound, and the doctors put on there a cystocele, what in the world is that? That's your bladder descending. And so when we talk about these things descending, it's not that the bladder itself has come out. It's actually come back down against the vaginal wall. And that is then in turn starting to invert down into the vaginal canal and potentially out of the opening of your vagina in the vulva, if we're using our correct terms. You can have the uterus slip down if you still have your uterus. And you can have your rectum sit down. We talked about the enterocele being part of the intestines coming down. Overall, these usually feel very similar. You might notice a bulge in your vaginal opening. I would say the number one thing that my patients come in telling me made them realize they might have an issue is when they were washing and they notice some sort of soft tissue at the vaginal opening that they don't normally feel. That's one of the number one things. Sometimes it's a really big, heavy pressure. Sometimes I'm getting people that have been seeing PT for years for their back pain. It's just never really resolved. And then we realize, oh, it's actually because your uterus has started to descend down, and those ligaments that hold it up that attach to your sacrum, this guy right here, right? Those are putting so much stress that they're making your back hurt a little bit. So those are, I think, overarching the things that I see. You can have some more individual based on the organ itself that's impacted. The bladder, as it's tipping backwards into the vaginal canal, it makes it so that the lowest point of the bladder is no longer the output through the urethra. It's now a little pocket somewhere in the back. And so when I go to stand up, when I'm done peeing, a little bit more came out because now gravity has tipped it all out. With the rectocele, where the rectum is descending, we like to have a nice straight shot from the rectum to the anus that lets bowel movements pass easily. And if we don't have that because, I don't know, the rectum's bulging into the vagina a little bit, it can make it hard to have a bowel movement, all right? You might find that if you put a little pressure up against the vulva or even place a finger in your vaginal canal, it makes it easier to have that bowel movement. And that might be a pretty good sign that that might be part of your problem there. So again, some things that all of them have in common, pain with sexual activity. I find sometimes people actually feel a little bit better after having sex, especially if it's not a very severe prolapse, because their partners kind of push that organ back up in place temporarily. Another thing that is typically common with this is that you feel worse at the end of the day. And it's because of gravity. You've been standing, you've been moving, you've been potentially doing a lot of heavy work in the garden or out shopping, and it's put pressure down on those organs and they're sitting at their lowest. And then people usually feel best in the morning, or, oh, if I lay down with my hips up or even just with my feet up, I feel a little bit better for a while. That might be a pretty good sign as well. What can you do right here, right now, without having to get a referral necessarily, without having to worry about, am I going to need to have surgery? We talked about pessaries. What are pessaries? I apologize. I did not include a picture of pessaries in this particular presentation, I don't think. But a pessary is a little medical grade silicone object. They come in different shapes based on the support that you need, that the doctor fits for your anatomy and your needs, and you just place it in the vaginal canal. Now, these are not your grandmother's pessaries that it goes in and then they have to go back in every 3 months to get it taken out and cleaned. If you have some issues with your dexterity and it's hard for you to do that on your own, yeah, they might make an appointment for you so that they can come in, check, make sure all the tissues look healthy and happy, clean that pessary, put it back in, send you on your merry way. But if you have that dexterity and you're able to take it in and out yourself, you get to manage it, no problem. I actually know a lot of pelvic floor physical therapists who have a little bit of a prolapse. They use a pessary when they're working out, and then otherwise they don't really need it. So it's a really great option if you just need a little extra support. You can get supportive garments. So sometimes just a nice tight pair of yoga pants provides enough pressure up against your vulva that you get that support. There's also garments that you can look up that give you specific support. And I didn't write this down, so if you have a pen, there's one called a V2 supporter. V is in Virginia. And that it looks kind of like a female jock strap. And you put it on under your clothes. It gives you a little extra support and pressure. Physical therapy, of course, shameless plug. Learning how to avoid the things that can cause a prolapse to happen in the first place. So a lot of times straining habitually for bowel movements because maybe you don't drink a lot of water because maybe you've got a little bit of urinary incontinence, so you're not drinking as much water, and therefore your stools get harder and they're harder to pass. Or maybe you did a job that for years and years and years required you to lift a lot of heavy things. And over time, you just got that constant pressure and it stretched out the ligaments. So learning how to move properly can take a lot of strain off of this area. And again, this is something that I can absolutely help with. For some people, weight loss makes a difference, especially in menopause. We tend to get our weight right at our abdomen. And if part of the problem that comes with a prolapse is a pressure management issue, and now we have this additional weight that we just don't like sitting right on our abdomen applying pressure, then that can contribute to that intra-abdominal pressure down on those organs. And then we talked about, it's called splinting, when you apply the pressure up against your vulva or even place a finger or a thumb in your vaginal canal so that it's easier to have a bowel movement. I'm a big fan of squatty potties. Those little toilet stools that you guys see, they're kind of a U-shaped usually. Everybody should have a squatty potty, unless you're like over 6 foot tall, in which case you've got a built-in one. But I feel like everybody should be having a squatty potty, even if you don't necessarily have issues with bowel movements. Things to avoid: straining with the bowel movement. Make sure you're hydrated. Make sure you're getting plenty of fiber. Even if you think you're getting enough fiber, you probably aren't. As Americans, we just aren't. Our nutrition system isn't set up for it. Limiting the constipation. That feels obvious. Valsalva moments. So Valsalva is when I pick up something really heavy and I hold my breath to do it, and it gets a whole bunch of pressure down into my abdomen. Or if I'm straining to have a bowel movement, I'm holding my breath and I'm pushing, right? We want to try to avoid those things. The posture where everything's kind of curved forward. Sorry, everybody online, I'm going to step out of view for a second. But when I curve forward, can we see how that closes down over my abdomen, right? And immediately that puts pressure down on the perineum. Perineum is the fancy word for the area under the vulva. Sorry. So that is prolapse. The second thing that I wanted to talk about, that I've done a couple presentations now for TMC for seniors, and I don't know that I've gone into great detail about bladder urgency. So I wanted to talk a little bit more about bladder urgency specifically, because it can be really problematic, but it's relatively simple to fix for the most part. Bladder urgency is an urge that comes on sudden and it's really hard to ignore. All right. So that, I've been waiting 2 hours and I drank a liter of water or a liter of iced tea and now I have to pee. I wouldn't say that necessarily counts as a bladder urgency issue. You might just have a very full bladder at that point and it's time to go. The bladder is not an infinite capacity. It also can be triggered by a certain situation. I have had patients in the past that they have one specific bathroom in their house that when they walk by that door, they have to go. The other bathroom, it's fine. That bathroom, I had another patient that she was a caregiver for her husband, and taking him to the bathroom was the trigger for her to have to go. So I guess at least it was convenient. It may or may not be with leaking. There is something called urge incontinence. And that is when I have an urge, that very sudden, strong urge to go, I can't stop it. It's going to come out, right? In some amount. Versus a stress incontinence, which is I cough, I laugh, I sneeze, and a little bit comes out. I jump on the trampoline and a little bit comes out. And it's not specifically associated with frequency. So you can go frequently, but not have urgency. So one of the big things that can lead to urgency is, I know I have some urine in my bladder, and my grandma always said that you should go when you feel like you need to go. Anybody else's grandma said that? Yeah. God bless her. Yes. But what we don't want to do necessarily is, as soon as we feel like we could go, we don't necessarily want to go. I would say if you're getting ready to go out and you know that there's not going to be a bathroom, if you're going to go for a drive, you're heading up to Phoenix for something, great time to go ahead and go, right? Or if it's been a couple hours and you're like, well, it's been a bit, so I think I better go ahead and go. Otherwise, every 2 to 4 hours is a normal time to empty your bladder, all right? That ends up being like 5 to 8 times during the waking hours. What are some potential causes of bladder urgency? Well, we already talked about you can actually train your body into needing to go more frequently. So if I go on the hour every hour, eventually my bladder will learn to go on the hour every hour. My favorite analogy in the clinic is your bladder is a puppy and it's going to do what you train it to do. So be very careful what you train it to do. Weakness or tightness in the pelvic floor muscles. This is a really interesting concept, and this is one that I harp on every time I come in because it's the number one thing I talk about in my office space. Tight muscles aren't strong muscles, all right? If we're thinking about my bicep, and if my bicep is always tight and I'm holding everything like this, if you ask me to pick up something else, I can't, right? I can't reach down to get it. Or if I'm already holding a lot and you add more, eventually my strength is going to go, right? Also, if I'm never letting my muscle relax out of this position, I'm never strong in any other spot, right? So tight muscles are intrinsically weak muscles. So I want to separate the idea of weakness, meaning looseness, which is one of my least favorite terms in my office. But you can have tight muscles that are also not strong. Weakness in the core and the hips. Core is not just your abdominal wall. Core also includes your back muscles, your lats, and your glutes, your butt muscles, right? Core also includes your diaphragm, your breathing muscle. It's got to be able to move, all right? It does include all 4 layers of the abdominal wall, so not just the 6-pack, guys, okay? They are there. Even if they've got a little extra insulation, they are there, and we need to have them nice and strong and coordinated. And that, make a point I didn't even put on there. The muscles have to work together. If they're strong and they're just firing when and however they're supposed to, that doesn't necessarily help you. They've got to be able to turn on at the right time, in the right moment, with the other muscles in order to get that support that you need. The bladder training, that's your puppy, right? Some people have neurologic issues. Stroke can sometimes lead to this. Parkinson's disease can sometimes lead to this. Diabetes, especially if it's not well controlled, that's usually one of the first signs that you go into the doctor and you're like, I'm peeing a lot. What's happening? And then, oh, it turns out blood sugars aren't well managed, right? So looking at some of those things. Regularly ignoring your body cues to empty your bladder. I'm not going to call anybody out, but if anybody in here is a retired nurse or a retired teacher, you guys are the number one. Thank you for being honest about it. You guys are the number one issues with this. My mom's a teacher and my grandma was a nurse. I'm allowed to say these things. You don't always get to go when you need to go. And so you sometimes have to ignore it. And what that can lead to is maybe a bladder that's gotten stretched out over the years. Or maybe just it's really hard to actually stop and listen to your body now that you have the time to be able to do that, right? That's a skill we have to learn. And then food or other ingredient irritants. Citrus is often a big one. Things that have artificial sweeteners. Things with caffeine, and then things that are carbonated. Those are the 4 that right out of the gates I like to talk to people about. You can look up online and find all sorts of different things that might be your issue. My recommendation is take a couple days, write down, get yourself a little schedule, write down when you went to the bathroom, if you had to run to the bathroom, and then also track everything you're eating and drinking, all right, as best as you can. And then you'll start to see a pattern of, oh, when I had that lemonade at lunch, by the time I was leaving, I had to run to the bathroom because it had enough time to hit your bladder. All right, so that's urgency. What do I do about it? This is from a handout that I give my patients in the clinic. I call this the 4 S's, or how to retrain your puppy. So the worst thing you can do is when that urge is really high and you're thinking, oh my gosh, I'm going to have an accident right here. The worst thing you can do is run, right? Because I'm reinforcing that urgency. My body is in this heightened arousal state. And now I've encouraged it. I've reinforced that, yes, we need to be scared. And I've run to the bathroom. And that can make it worse over time. It can actually make the urgency get worse and worse and worse. So the first thing you got to do is stop. If you're standing, if there's a wall, maybe lean back against your wall so you've got a nice firm surface. If you're already sitting, stay sitting. Get yourself seated. Make sure that that space around your genitals is nice and firm in contact with whatever you're sitting on. It's kind of like a little kid holding themselves, only with a little more dignity. And then maybe you try a couple Kegels. I have another slide that's how to do Kegels here, but maybe you're doing a couple little squeezes of the pelvic floor. For some people, a squeeze and hold works well. For some people, a couple longer squeezes that they hold for a couple seconds. For some people, it's more of a rapid on-off. I would really encourage you after you contract to try to let all the way go. Don't do these little flutters because those don't always have the same effect. Try not to think about your bladder. This is the hardest part. If you're not super aware of your pelvic floor and how to engage it, sometimes that in and of itself is enough sidetrack. If that's easy peasy, but all I can think about still is my bladder, or suddenly a waterfall is imagining in your brain in the background, or a little drippy faucet. Try to think about something else. What are you having for dinner that you're looking forward to? Do you have any trips coming up that you're excited about? Are there any celebrations that you're looking forward to? And then once that urge has come back all down to a manageable, reasonable level, or maybe it's gone away entirely, go ahead and go to the bathroom. Good puppy. You waited. Now you get to go. Right? As you can make it to the bathroom without having any urine come out, but is on the porcelain, urge hasn't come back, you can start waiting a little bit. Start with this at home. It's a little scary to do out in public, right? But reward success. Never try to push yourself to the limit. I don't recommend waiting until the urge comes back and then going, because then it usually comes back with a vengeance. But reward your bladder. Hey, we did what we want to do, just like a puppy. Train what you want to have happen, right? It's easy. We're all just animals. Okay. So those were the 2 big topics that I really wanted to go over today. And so now I like to do a little shameless plug about what is pelvic floor physical therapy, because inevitably I end up seeing a couple of you guys in the clinic, and it's really nice to have you guys already know what we could be doing. What does it include? I like to describe pelvic floor physical therapy as a buffet. All of the parts are really important. They're important to different degrees to different people. I typically don't have a strong opinion on which parts we do first. I kind of leave that up to you. I'm one of those evil physical therapists that you come in and I say, what do you want to do today? And then I sit there and wait. So I like to talk about what we can do. Almost any order. Periodically somebody comes in and I say, hey, this happened right after you had that hysterectomy. I'm really curious to see what's happening with your pelvic floor. Is that okay? All right. So sometimes people come in and they really don't want to do the pelvic floor part of things, which we'll talk about in a second. And that's okay. But I always tell them, if you came into me for your shoulder pain and I never looked at your shoulder, you might give me the side eye a little bit and question if I know what I'm doing. So it's not always the most pleasant, but I think it is really important. And we try to make it fun. And I would say, if you're not seeing me, you're seeing one of my colleagues that does this. We all try to make it fun because we know it's not pleasant. We've been there. When we take our pelvic floor classes, we learn on each other. And man, that first class, you're sitting there going, okay, I'm going to take off my pants behind this sheet. So we understand. By the end of the first class, everybody's running around without pants on. So it's not going to be weird for us. Don't worry. Okay. What is that pelvic floor assessment? It is an internal assessment via either intravaginal or intrarectal cavity. The way I run this is how I have described on here. If you go see a different physical therapist, they might do things a little bit differently. We all have working with our own strengths, that sort of thing. So I have people undress from the waist down. It's not the gynecologist. I'm not going to do a breast exam, so you get to keep your shirt and your bra on. No problem. Bring warm fuzzy socks if you get cold. My treatment room tends to be kind of cold. I will have people either lay on their back, usually if I'm doing a vaginal assessment, or I might have them lay on their side or their stomach for a rectal assessment. It just depends on what is comfortable for you, what's the most easily accessible way for me to get to the canal that we're needing to assess. Periodically, somebody has something like a lot of vaginal atrophy related to menopause, or a lot of tenderness, or they might have a skin condition that makes it so that they can't have a vaginal assessment. We can do a rectal one. Typically, I prefer to do, and my patients prefer to do, a vaginal assessment when there's a vaginal canal available. I start with a visual observation. Again, that word perineum. I'm just looking at the areas around the genitals. I want to make sure your skin looks healthy and happy. Periodically, I'll find something that I'll say, hey, let's get you back in to see a gynecologist or at least your primary care so that we can get that checked out and make sure that's not part of our issue. I want to see if menopause is way in the rearview mirror for you. I want to make sure that skin is all looking healthy and happy. There's not dryness, there's not irritation, there's not any sort of issues like almost like a chapped lip sort of situation, right? That in and of itself can lead to some bladder urgency. I will palpate those muscles. So I start externally, just a little bit of pressure. If you reach up and you feel the bottom part of your eye socket, that's about how much pressure I'm using. It's pretty light. It doesn't take very much for me to find out if there's something going on with those muscles, right? And then if it's appropriate, if those muscles aren't super tight, they're not super irritated, we got all the way through all three of the pelvic floor layers, then we'll talk about Kegels, looking at strength, looking at endurance, looking at coordination, 3 different pieces to that puzzle. What else will it include? Well, the rest of it kind of looks like your regular physical therapy. So if you've ever been to physical therapy before in the past for hip pain or back pain, or after like a hip surgery or a knee surgery, it's going to kind of look like that. Like we said, I want to see how all of those muscles are working together. Often pelvic floor dysfunction does not exist in a vacuum. And I would argue that a lot of times it's not actually the original issue either. It often comes around because there was an issue somewhere else that didn't get resolved. And so therefore, the pelvic floor tried to act like the straight A student in the group project and pick up the slack for everybody else. So we're looking at, how do you move? How do you stand? How do you walk? Are you strong? Are you coordinated? I'm looking at, how does your abdomen feel? If you've had a lot of abdominal surgeries in the past, I want to see, is that maybe part of our problem? Is there some scar tissue or some adhesions we need to work on? If you've had an inflammatory bowel issue, maybe that's part of our problem. I also want to see how you breathe. Are you breathing into your chest? Are you breathing into your belly? Are you breathing into your ribs? Can you breathe into your pelvic floor? We need it to go all the way around. Some other treatment options. So that was all the assessment. We might do some manual techniques. If those muscles are tight, they're just like muscles anywhere else. They would benefit from us giving them a little bit of an input, either with some manual techniques, some muscle releases, or maybe some stretching. Or I even do something called dry needling, which is using acupuncture style needles to ask the muscles to relax and reset via the nervous system. We're going to look at exercises. We're going to look at exercises for strength, for endurance, for coordination. We're going to look at them for the pelvic floor. We're going to look at them for the rest of the surrounding muscles, right? Kegels, maybe. Stretching, yes, pretty much everybody. Some other exercises I really like are, I would put these in the other order, pelvic tilts, where you're just trying to get your back nice and flat into the table using your tummy muscles. Bridges, where you're picking your hips up off the table. And clamshells, where you're laying on your side, lifting your knee up like a little clam, opening and shutting. We're going to look at your breathing mechanics. This is day 1, visit 1, what we do across the board for pretty much everybody. Biofeedback. Sometimes your doctor will say that they want you to have something called biofeedback. And typically what they're talking about is us using electrodes attached to the outside of your body around, I do it around the anal sphincter, so that you can see on a graph what your muscles are doing. We typically don't get to that day 1, but we often get to it later on. Assessment, correction of mechanics and posture. If we think back to what we were talking about with prolapse, yeah, we want to make sure that that either doesn't get worse if you've had it repaired, to make sure it doesn't come back, right? And lots of education. I'm the queen of handouts. I've got like 2 wall organizers of handouts. So lots and lots of education. All right, as promised, how to do a Kegel. Again, caveat, Kegels are not for everybody. If you have a lot of issues with constipation, with pelvic pain, with burning, with urination, maybe don't do these today. Maybe start with some breathing and some stretching instead. But when you do a Kegel, you can do a couple different visuals because these muscles do different things even though they all work together. Maybe you're sitting there thinking about closing the opening of your vagina. Maybe you're thinking about closing the vagina and then squeezing and lifting it up towards your nose. Maybe you're thinking about squeezing as if you could stop the flow of urine, the flow of gas, or to prevent a bowel movement. Side note, I don't like people to do Kegels while they're urinating. Pelvic floor should stay relaxed when the bladder's emptying. So if you've ever heard that somewhere or a doctor has told you that, throw it out. Don't do it. Another one you can do is squeeze as if you could lift your bladder. Sometimes that works well for people. That one's a little different. These are bowl-shaped muscles, which means that when they contract, they don't create a visible change like your bicep would or like your hamstring to bring your heel to your bottom. Instead, what it means is when they contract, they flatten. I think it's easier to visualize the diaphragm with this. So again, I'm going to scoot out here. So when we're breathing, when we're at rest and we've exhaled, our diaphragm sits like this. When we breathe in, our diaphragm comes down to pull air into the lungs. The pelvic floor then is a bowl the other way. When we contract, it lifts up and flattens. When we breathe in and relax, it drops down. All right. So that's why we're doing lifting motions. And then a little bit more about physical therapy itself. How long does it take? It depends. Depends on a lot of things. It depends on if you've just had a surgery, if you've had a surgery in the past, how long ago was it, how was your healing with that? It depends on how bad are your symptoms. It depends on how in tune with your body are you. Are we teaching you again how to listen to your body, right? And how good are you at it? It depends on stress, right? It depends on your general health and activity levels. It depends on how much you do your homework. I give a lot of homework. I see my patients usually once a week. And I give you a lot of things to do at home because my goal is not just to fix your current issue. My goal is to make you your own best therapist. I want it to be so that you don't need to come back and see me again in the future unless something else happens. And I want you to understand why we're doing the things we're doing because I think that makes it more pertinent. I think it makes it easier to do the things at home. And then the length of the treatment, it depends on a lot of the above factors, right? It depends on how bad are things, how long has it been going on, it depends on how many things you have going on. I had a patient once that thought that it was going to be easier to treat her because she had a lot of things going on. And I was like, well, it's not like horseshoes. Bigger target doesn't make it easier. So sometimes it just takes a little while to pull all the pieces together and to figure out which things need to happen first for you. And then this is how you come see me. And again, you should have all of this. The biggest thing is here and at most hospitals, we require a referral for you to come see us. Pretty much anybody can send you that referral except for maybe your dentist or your chiropractor, okay? So these are the people that I'm commonly seeing when I get referrals. I'm a big fan of people still seeing gynecologists, even though you may be through menopause and maybe they've told you you don't need a pap smear anymore. You still have the parts. It's still worth going to a specialist, in my opinion. If that's a really hard thing for you to do, make sure you're having these conversations with your primary care. They're not going to feel embarrassed about it. You shouldn't feel embarrassed about it. Our fax number that it can be sent to is here. If your doctor is within TMC, they can do it within our internal medical record system. And then our clinic phone number, if you have questions, is at the bottom there. Here are my references that I used. And then thank you all for being here. All right, Maya, we're ready for some questions.
So thank you so much, Sam. So I do have some questions that came in. I had a question right away that came in about the Emsella chair for bladder incontinence. Can you share what is that?
So
And
the
what
ImSolid,
do you do?
yeah, the ImSolid chair uses an electromagnetic current. It has, I believe it's like an MRI that has magnets that spin in it, and it creates an electrical current that you literally just sit on it like a chair. It's not a very comfortable chair, no cushion, and it sends an electrical current through your pelvic floor muscles to get them to engage. There is some reasonable research around its efficacy. The questions I always have, and I think we'll be seeing more research about this, is the long-term outcomes. Because the reality is you're going in, you're sitting on a chair, it's zapping your muscles. And so you might be getting some initial and at least some short-term improvement in that muscle function, which can manage the symptoms. But I have questions on whether or not long-term it's really going to correct the issues, or if people are going to have to continually go back and do it because they didn't actually learn how to use their muscles.
Okay. Another question is, how does pelvic floor health relate to chronic illnesses, maybe such as like IBS or lower back pain?
Yeah, I would say they're pretty intrinsically entwined. IBS, especially if you've had to do a lot of lifestyle modifications to manage your symptoms, that can lead you to have some poor toileting habits. I would say that qualifies in the group of things where I see sometimes some abdominal visceral issues where those abdominal organs are just not in a happy state. And so we've got to work on the tummy a lot. Low back pain, like we talked about. The ligaments that hold the pelvic organs in place, they attach primarily to the back of the back of the pelvic wall. And then also there's a shared fascial connection. Fascia is a soft tissue that goes throughout the body that helps with our stability structure. So that's a hard question to answer just because it's so broad. But my biggest recommendation would be, if you feel like the traditional care that you would get that's been offered, like regular physical therapy or just diet or just like a colonoscopy sort of thing, if that's not seeming to cover the bases, it might be really worth getting a pelvic floor assessment to see what's happening there.
Okay. And can medications cause urgency? And if so, how do you combat that?
Yes, they can. I'm going to blank on them off the top of my head. I'm sorry to whoever asked that. It's one of those where it's a little bit hard because sometimes it's a situation where it's going to be something you have to be aware of. So one, arguably not specifically causing urgency, but when people are on diuretics, that can cause some issues with frequency, and you're pulling more water out of the system more quickly, and so your bladder's filling up more often. So that's one that you just kind of have to be smart about when you're taking it. Talking to your doctor about, can I take this in the evening when I'm at home versus in the morning? Can I take this, right after dinner so I have time to get that fluid out before it's time to fall asleep? And then potentially seeing if there's an alternative medication that maybe your system isn't irritated by. Yeah, that's a hard one though.
Okay. Can you overwork the pelvic floor with PT and exercises at home?
I'm going to answer that two different ways. One that I see, and this can happen quite frequently when somebody truly just has some weakness in the muscle. The muscle is just not very strong. It's not engaging as much as we want it to. Arguably, actually, I would say this also is true for people who have tight muscles that we've taught how to have muscles that are longer. The muscles aren't strong. So it's just like any other workout. If I go and I do a bunch of squats at the gym, and then I want to be able to go out in my yard and move all the concrete pavers that I've been putting off for the last 6 months, that's going to be really hard for me to do because I already worked out those muscles, right? So it's just like same thing with the pelvic floor is if I'm doing a bunch of my Kegels or I've done a bunch of endurance training with my Kegels, and then I'm getting ready to go to like a concert, you might, well, if it's a sitting concert, it might be a little easier, but a standing concert or walking around the farmer's market might be a little bit more challenging just because you've already worked out those muscles. So I usually recommend people at the beginning, prioritize doing your exercises in the evening when you're going to be home for the day. And then as you build strength, then you can start doing them more throughout the day instead of just in the evening when it's maybe you don't need your muscles quite as much. Rarely, but periodically, I get people who get what we call DOMS, delayed onset muscle soreness, kind of like after you work out and your muscles are sore for like 2 or 3 days after. Every now and then I get somebody who gets that in their pelvic floor, but I would say that's not super common.
Okay. So if, when you see somebody for pelvic floor, they have their assessment, how long are you normally working with them? And is that usually like once a week that somebody is coming in, or what does that look like?
Yeah, and that was on that last slide, or one of the last slides for people. I see people once a week. The amount of times that I actually see people, like the number of weeks, it's really variable. If it's something where it's just oh, hey, you actually don't know where your pelvic floor is, I just need to teach you how to find it and turn it on. I've had people that are in and out in like 3 weeks, because that was really the issue. If it's something that's been ongoing for a long time, or maybe it's related to an illness where for the bladder, maybe you had a catheter in for a long time, or you had a cancer treatment around the pelvis, that sometimes can take a while longer, just because it's a little bit more involved.
And if you finished up treatment with somebody, is it possible that somebody might need to come back at some point?
Yeah, I would say so. Often when I've had repeat patients, the biggest thing is that they've stopped doing the exercises. Sometimes people come in and they've had something different happen. Maybe they had an illness that caused them to have issues, or maybe they had a procedure that caused them to have issues, and so therefore it's different. But I would say often when I'm getting people, if it's the same thing, it's usually because they didn't continue. So I learned this phrase from one of my professors in PT school, and she used it a little bit differently, but how I've hybridized it is that exercises are like green leafy vegetables. You don't get to eat them just once and have the benefit the rest of your life. You have to continue to eat them. And then she always meant it, and that green leafy vegetables are good for everybody, and so are exercises.
Okay, great. My last question is can mindfulness or meditation help with urgency in addition to PT?
Yeah, for sure. I would say that fits under that sidetrack in the 4 S's. If you're kind of thinking your way out of it, especially if it's an urgency that you kind of have already figured out that, yeah, I don't really have to go. There's some sort of trigger that can often help.
Okay. I want to go ahead and put up for our online audience the phone number for TMC Outpatient Therapy. It is 520-324-7005. If you have any questions or you're looking for an appointment, you do need a referral, as Sam mentioned, so you would need to provide that as well, but that is the number. I want to thank you so much for being here, Sam. I'm going to close up with our online audience, and I'll turn it over to you for any questions in person. Thanks for being here.
Thank you.
Thanks again for joining us today. We look forward to having you back next week. We've got a couple of talks we'll be doing. One is on Wednesday, May 21st at 2 p.m. That is Skin Deep, the Essentials of Skincare and Aging. And then on Thursday, May 22nd at 10 a.m., Navigating Chronic Kidney Disease. If you are interested in either of these classes or any of our other classes, please feel free to give us a call. We'd be happy to get you registered. Our phone number is 520-324-1960. So give us a call. We'll get you registered for any of those classes. We look forward to seeing you again next week. Thank you.